no problem. You can share it later. It's okay. Okay. Yeah. We'll do it. We'll do it. Hello and welcome to Health Live at Seniors Today. We are in the midst of the Ganpati season, and those of you who are watching us live, greetings on the season, and I hope all of you are enjoying yourself well. We have here with us once again Dr. Vishal Chafale. Dr. Chafale, if you remember, was here with us a few months back, and he had spoken about Alzheimer's disease. This is the Alzheimer's month, and we thought that we would request him this time to speak on dementia and a very important part of tips for caregivers. I will introduce Dr. Chafale once again. He is, as we all know, a highly regarded neurologist with extensive experience. He practices at the Apollo hospitals in Navi Mumbai with nearly 2 decades of experience in this field. Dr. Chafale specializes in treating a wide range of neurological conditions, ranging from strokes and prevention to headache, epilepsy, Parkinsonism, and neuromuscular disorders. Dr. Chafale collaborates with physical therapists to develop management strategies for patients with neuromuscular disorders, aiming to improve their overall movement and quality of life. His dedication to the field of neurology is evident through the various publications in medical and neurology journals. A graduate of leading institutions, he holds degrees, of course, the MBBS, the MD, DM in neurology, and the DNB. He's earned a fellowship for interventional neurology, showcasing his commitment to advancing his expertise and providing the highest standard of care to his patients. Welcome to Health Life at Seniors Today, Dr. Chafale. How are you?
I'm good. How are you? Okay. Thank you for again giving me opportunity to interact with wonderful people. So today, as we will discuss about the dementia, it will be the extension of my talk, and I will cover various aspects of the dementias, and we'll discuss how, as a caregiver, we can help our people who are suffering from the dementias.
Right. Thank you, Dr. Chafale. As always, do note that this session is being recorded, and the recording will be up on the Seniors Today website on Monday evening. So you can have a look at the video that is there. So you don't need to take notes just now. You can always watch it once again on Monday. The takeaways are, as always, written by a qualified medical practitioner, and so you can read all of that. So right now, just watch it, and in case you have any questions, please put them in the chat window to meeting group chat, and we will then address the questions to Dr. Chafale after his talk is over. Over to you, Doctor. You're on mute, Doctor.
I'm mute.
Yeah.
Just okay. Am I audible and am I visible?
Yes,
okay.
You are.
So we'll start. So dementias. As a neurologist and as a practicing in neurology for last 1 decade. So I have seen a lot of people and growing incidences of dementia. So one common thing is like our life expectancy is more nowadays, because so various illnesses are now treatable. So our life expectancy is more. So our elderly aging population is more. So similarly, that's why we are seeing more and more people having this forgetfulness, because we are seeing a lot of aging population because of increased life expectancy. So dementia is a common problem. It is going to occur with the advancing age. 10% more than 70 years, and more than 80 years, almost 20% people will have some form of dementia. So this is the magnitude of this problem. So let us discuss briefly what is dementia as a doctor, and what are the causes, and how to identify the people having dementia and how to help them. So first of all, when I say dementia, means dementia is a loss of cognition or impaired cognition. So what is this cognition? Cognition is a mind function where we become aware of the different objects we perceive, we remember them, and we associate them, and whenever there's a context, we can recollect this thing. So this is a function. Everybody have this function. Nature has given this function. So this is normal cognition. When there is impairment of this remembering capacity, then there is a problem with the memory and perception, understanding. So that problem, when it affects our day-to-day activity or activity of daily living, so it becomes significant, then we call it dementia. So dementia is a acquired, means it is not there since birth. With time it comes. It's a global impairment of the intellect, memory, and personality. So there are different domains of the brain which affect, and they give different features. So dementia affects variably some of these domains, and ultimately a person loses the capacity to live a normal life, and they need a uh, assistant for their day-to-day activity. So this is called as dementia. Here the person remains conscious. So somebody is very much conscious, still he is not able to perform his cognition, higher mental functions. Then we call it dementia. So dementia is forgetfulness. Normally it will start, and slowly it will progress. Early stages we don't know most of the time, because there can be very variable subtle features. Then these people will find difficulty in doing familiar tasks. Simple things they used to do regularly, they may find it difficult initially, and at later stages they may not be able to do it at all. Then they will get confused. Then that person may have poor judgment, normal capacity to take logical thinking, that will be poor. There will be decrease in intellectual functioning. So when this thing occurs, this cluster of symptoms, we call it dementia. So dementia is a degenerative problem. When we call it particular dementia, when somebody, we label somebody as a dementia, so it's a degeneration. So it will not happen overnight. It will start slowly, very slowly. That initially first few years, maybe first few months, nobody, even person, will not know that he is having dementia, because always there is a compensatory capacity of the brain. Suppose my 5% of neurons are lost, my 90% of brain will take over, and I will not manifest my simple symptoms of the forgetfulness, because there is a capacity of brain to take over. Similarly, there is 10%, 20% neurons are lost. If my other brain is healthy, that will still keep functioning normally. And at some point of time, this loss of compensation will go, or the degeneration will become such a significant that the features of dementia or forgetfulness will start getting out. That is a stage where we start noticing features. So when we start noticing the forgetfulness, the problem of that degenerative dementia must have started at least few months or few years. And that's why now we are seeing the dementia, because there is significant loss of neurons. So that is a part of degenerative dementias. So whenever a dementia comes or forgetfulness comes, so we label them whether they are primary or whether they are secondary. This is very important, because if there is secondary, means there is some other cause for cognitive decline or memory disturbance, then I have to treat that cause. And high chance that suppose I treat that cause, the cognition, memory will improve. So it becomes treatable. So as a doctor, whenever a person comes to me with a features of dementia, my first goal is to decide whether it is primary or secondary, because that will change my line of management, my discussion, my investigations, everything. So there are certain reversible or treatable causes. Means not all forgetfulness, not all memory disturbances are dementia. First, we have to rule out any treatable or reversible causes. And in most of the times, once you reverse that cause, your memory, your dementia will get reversed. So we'll not label it dementia because it is just cognitive impairment due to some reversible or treatable causes. Most common cause is stroke. Suppose a person has suffered a stroke and it is affecting the memory area. His feature will be memory loss, but it doesn't mean that he is having dementia. He is having forgetfulness or some cognitive decline secondary to the damage because of this stroke. Sometimes that damage may improve. As stroke improves, edema subsides, it may improve. So it becomes treatable or reversible cause. Similarly, suppose there is a tumor or any SOL or granuloma or something slow growing thing into the brain, and it is strategically associated or located in an area which maintains my cognition, my Papez circuit, my different lobes, and the cognition, the junction points of those circuits. Then again, the person may have dementia features, though he is not having actual dementia, but because of tumor, because of some granuloma or some mass effect, mass in the brain, there will be features of dementia. So again, it becomes treatable. Once I do the surgery, I refer the surgery, I remove the tumor or that clot, person may improve also. Certainly, there are certain metabolic derangements in the body. Somebody is having a deranged liver function, deranged kidney function, high increase in the urea creatinine in the body, or sometimes a very deranged ammonia level or deranged hepatic function. Still, they may behave as a dementia people. So it becomes reversible once you treat the kidney failure, once you treat the hepatic failure. Severe hypothyroidism can present as a dementia. So once you treat a thyroid, if it is very severe at that time, it may manifest as a dementia. Then there are brain infections, meningitis, encephalitis. Sometimes severe brain body infection may secondarily affect the brain. So these become reversible causes. There are toxins, some like alcohol intoxication. A person is dependent on alcohol, may develop some dementia features. And once you achieve the abstinence, the features slowly may reverse also. Sometimes our Indian people, they keep taking a lot of some preparations, and they don't know that they are taking heavy metals. So we should be aware before taking any unauthorized or any unprescribed medicines or preparation. So which may include lead and arsenic, and ultimately they may become the cause of the dementia or forgetfulness. So these become treatable. Some vitamin deficiency, vitamin B12 deficiency can cause memory loss, hypoxia. Sometimes a person have accident, trauma that may affect the memory, and so these are becomes a treatable, at least partially treatable. Suppose minor trauma is there and it is transient affecting the brain function. Once the brain recovers, the memory will also recover. But if it is significant memory, there can be residual deficit. But ultimately, they come into the reversible or treatable causes of forgetfulness. We don't label them dementia. Then what we call as dementia? Coming to this different dementias, we call it degenerative dementia. These are the actually category of the people where we label them dementia. Most of them are degeneratives, means some degeneration is happening at the brain level. Some supportive proteins, they get damaged, or certain accumulation of some abnormal protein tangles into the brain cells, neuron cells, and ultimately they don't function properly, and ultimately there is degeneration. So these become dementia. We call it degenerative or primary dementia. Most common type of primary dementia is Alzheimer's disease. There are a lot of other primary dementias like frontotemporal dementias. There are very different varieties. Then in India also we see DLB, dementia with Lewy body, Then advanced Parkinson people may have dementia. We call a Parkinson disease dementia. There are various other lot of subtypes degenerative dementia, but these are common dementias. As a neurologist, we come into practice. In our practice, we come across. So I will discuss about the Alzheimer's, and same thing can be applicable to other dementias. What happens in Alzheimer's and these different dementia? There is a different domains are predominantly affected. Our memory, I will just give brief idea about different domains. How our brain functions. Our brain have different lobes, which have their different functions. My memory predominantly is temporal lobe. My visuospatial ability. Suppose I am going back and going out and coming back from the same by don't not noting down the address. I can remember the topography. I can geographical location. This is into the my parietal lobe. We call it visuospatial memory. Then my frontal lobe. It is frontal lobe is anterior part of the brain, which maintains my social etiquettes, how to behave, how to talk, where how to maintain your hygiene, then how much to eat. Suppose I want to go to washroom, so shall I wait or not? These are social etiquettes. So these are maintained by a frontal lobe. And then there is a occipital, which maintains our vision and visual aspects. So everything is correlated. And these dementias affect this domain in different ways. In Alzheimer's disease, there is predominantly memory, temporal lobe, and parietal lobe. Our visuospatial association is generally affected. That's why a person having Alzheimer's disease, dementia, they will manifest in the form of forgetfulness. They will more forget things easily. They will not remember what they have done in morning, breakfast or dinner. They will forget it. Then they will have difficulty in navigating. Suppose they go out, they can't come back. They just lose their address. Even in a known surrounding, suppose they used to go out and come back. But in certain time, they may find difficult to find the address. So that is the Alzheimer's disease because of the degeneration of the parietal lobe. In frontotemporal dementia, as I mentioned, frontal and temporal lobe is affected. Here, there will be memory issues. But along with that, predominantly, there will be more of a behavioral issue because my frontal lobe is getting degenerated. So these people will be more aggressive. Sometimes they become gross change in personality. Sometimes they become less responsive. So it can be hyper aggressiveness or reduced interaction also. So this is called as frontotemporal dementia. Then in DLB or dementia with Lewy bodies, this person, they generally it is an elderly, they will develop dementia, they will have some form of Parkinson features. And in Parkinson disease, suppose it is very advanced, 20, 30 years, sometimes there can be a degeneration and which affects the brain cells and ultimately may cause dementia. So these are the common dementias we come across the practice, and actually these are the true dementias. Others are cognitive decline because of some temporary derangement into the body or some is assault to the brain, which sometimes recover at least partially. Now coming to the Alzheimer's disease, as I mentioned, it is a degenerative dementia, gradually destroy the ability to reason, remember, imagine, and learn. So the cause is then age is a most common risk factor for the Alzheimer's. Most cases of Alzheimer's disease and other dementia, they have mixed risk factors. So these risk factors are applicable for all dementias: age, family history, genetics. There are certain modifiable risk factor and certain medical condition. All these play together and give the features of the dementia. Age. Most of the dementia, they do occur in elderly. As I mentioned, almost incidence of dementia in 70s, 80s, up to 70s, 80s is around 10%. And more than that, age, after 90, 80 years or after that, octogenarian, nonagenarian, they will have almost 20% people will have some form of dementias. So with age, your dementia will worsen. But there are certain dementias, some Alzheimer's form dementia, they may occur in young age. Less than 60, they can have dementia. So there are different types. They affect generally different ages. But more by and large, dementia is a problem of elderly. Then family history in some form of dementia it is there, but sometimes it is a polygenic inheritance. Means it's not exactly that suppose your parents have dementia, you will exactly no, it's not like that. If your parents have dementia, chances of getting dementia slightly more than normal population. But there are certain forms which are genetic, which are very rare. Like Alzheimer's disease can be genetic, very rarely, less than, I would say, less than 5 or 10%, they may give genetics, but they are very early onset and all. There are certain modifiable risk factors, vascular risk factors. They damage the brain and they cause more early presentation in a person with Alzheimer's. So Alzheimer's is diagnosed in people over 65 years. Early onset dementia less than 65 in 5 to 10% of people. More common in women as compared to men. About 3% of men and women, 8 to 65 to 70% will have dementia. But nearly half of those having 85 years or more will have Alzheimer's. This is the incidence. So as it indicates, as your age advances, chances of getting dementia or Alzheimer's disease will more. What is the pathology? Why there is a forgetfulness in Alzheimer's disease? There is decrease of altered metabolism associated with the age. Certain normal functioning, normal mechanism of the neuron bodies which maintain their functioning, it get impaired with age, and there is accumulation of some protein tangles, and they damage the brain. That is the mainly main pathology. So ultimately, there is degeneration of the neuron. You can see there is some abnormal neurofibrillary tangles. They get deposited into the healthy neuron cells. There are amyloid plaques, and they ultimately damage the brain, and its brain gets shrink over a period of time. You can see this is a normal brain, and this is the Alzheimer people having advanced dementia, and they have this type of brain where there is atrophy of the brain, prominent gyral places. You can see prominent spaces of the brain. This is the temporal lobe which is atrophied. So this is actually picture of the normal brain, and this is a unhealthy brain. Healthy, unhealthy. You can see this is a healthy brain. Here, prominent sulci gyra over the brain. So this is there is a shrinkage of the brain. Volume of the brain becomes slowly low as compared to normal healthy population. As the dementia advances, there will be more degeneration. This is MRI scan, which is showing the this is a healthy on left side, and right side it is abnormal. You can see the prominent brain ventricles and loss of neuron parenchyma, and this is atrophy of the brain. So there is extensive investigation, and in 2014, actually, the Nobel Prize was uh, given to a group of scientists which were working in the Alzheimer's disease dementia. This is called a worst plaque of centuries. Till that, we don't have satisfactory treatment till that to reverse everything. So still the extensive investigations are going on, and let's see in future we may get some answers and some better medicines. So etiology, there are multifactorial, as I mentioned. It's not single. Environmental factors, infections, metal, toxin, some deficiency of different vitamins, they may contribute together to cause Alzheimer's or other dementias. There will be personality change, lack of interest in day-to-day activities. There will be easy mental fatigability. Generally, they are self-centered or withdrawn. There will be less self-care. So this personality change sometimes we may ignore. We may think that, oh, with age they are happening. But sometimes, if you see carefully, they can be the early features of dementia or Alzheimer's disease. Somebody is having fond of doing something, and suddenly he's saying, "No, I don't like it." So if it is affecting other activities also, then it can be a personality change associated with dementia. Then there will be a recent memory which is prominently affected. We call it episodic memory disturbances. Suppose we are doing some activity with them, like we have taken a breakfast together, or we have discussed some important topic, and you are asking them after 2 3 hours what we have discussed. They will just ignore the episode. That whole registered, that episode will not get registered. So we call it episodic memory disturbances. This is very common in Alzheimer's. These people, how they can recollect what they have taken in their marriage after 20 years, before 20 years, 30 years. Means wrong back, they whatever they have taken, they can nicely describe everything. But they will not able to describe or tell what they have taken in morning. So that is the problem, because recent memory is impaired, remote memory generally is preserved, at least in early stages of the any dementia, especially Alzheimer's. Then there will be disorientation, poor judgment, difficulty in thinking, abstract thinking, regional thinking, and reduce attention span. Then there will be personality changes, change in personality. There will be sometimes they become withdrawn, or sometimes they become more aggressive. There is a behavioral variant of the Alzheimer's disease also, which manifests, which behave like they are very aggressive. Otherwise, Alzheimer's dementia people, they are very calm, composed, and they will just forget things. They will not be aggressive. Sometimes they can be, especially in behavioral variant. Now coming to the stages. As I mentioned, is degenerative. So slowly, you will get different features. Early stage, there will be some features. Sometimes we may just disregard most of the features as age-related changes. There will be some changes in the cognitive ability, some memory loss, and as the stage advances, there will be more forgetfulness, more impairment of the language. They may difficulty in finding the name of certain important objects, simple objects, difficulty in reasoning. There will be abnormal sensory processing, conscious thought. Uh, so different stages. They see this timeline may be variable in every person. These are by and large. This is average. Mild stage lasts in 2 to 4 years, moderate 2 to 12 years, severe maybe advanced. But every person is different. Sometimes 10 year, 20 years person can have just only mild forgetfulness. They may not progress to the moderate stage. But sometimes after 5 years, after 4 years, they may progress to the moderate and then severe stage. So as the neuron loss increases, multiple domains get affected, and their cognitive capacity or ability to take their care of themselves will ultimately will reduce. Initially, there is a loss of memory, language dysfunction, mood swings, personality changes, impaired judgment, and reduced interaction, indifference to some certain things. With moderate stages, there will be inability to retain new information. There will be some behavior changes. Then there will be more agitation, aggression, confusion. They will need require assistance for most of their daily activities. And once disease becomes severe or advanced form of dementia, generally they are dependent on everything, virtually everything to the caregiver. They become bedbound. There is associated difficulty in walking. As there is a self care is lost, they become malnourished, or they are not able to feed themselves properly. So there will be nutritional problems in these people. They become bedridden. So this is a severe form of dementia, and advanced stage we generally see people in this condition. There will be impaired capacity to hold their bowel bladder, and they will need care for even simple feeding also. So this is a slowly progressive problem of dementia. How we diagnose a dementia? Suppose the person of dementia comes to us, how we diagnose? So first we take the history. So interestingly, a person with dementia, suppose a caregiver comes with a history that this person is having forgetfulness, but that person will say, no, I don't forget. Because actually the person of having actual dementia will forget that he is forgetting the things. That is the classical situation. The spouse tells, no, he's forgetting, he doesn't remember. And he will classically disregard. He said, no, I'm not forgetting, I'm absolutely okay. Sometimes the person says that I'm forgetting. The person himself presenting as a forgetfulness. So generally chances of having forgetfulness is less because they know that they are forgetting. So that's how it is. So most of the time the people ignore or they deny that they are forgetting because they say it is simple, it is normal for them. So it is a spouse or family members we who first notice the abnormal behavior or abnormal cognition. So we take detailed history. In OPD, we have certain tests. We ask them different questions which locates to a different brain lobe. So there are certain questions which target our frontal lobe, whether he's paying attention or not. There are certain questions or some drawings which target our parietal lobe, then memory. So we arrange a question. There are different questionnaires, and we take a score. In our day-to-day practice, MMSE score is commonly used, and once we get the score according to age, according to his educational level, which we decide whether it is abnormal or normal. This person is having very master's degree and all, making simple mistakes or one or two score less, maybe significant for them. In a person who is not educated and his score may be slightly low, which can be normal for him. So it depends on the intellectual level and cognitive pre-existing cognitive ability of that person. Once we diagnose that though there is some abnormality, we may subject them for detailed questioning, which includes a lot of detailed tests, minor things we pick up, and we advise MRI because our aim is to find out any treatable cause. Sometimes we get elderly, there can be a subdural hematoma, there can be some small SOL. Sometimes we get surprises and we treat that thing, and the patient may become normal also. So we advise MRI, that is the preferred investigation in dementia. Sometimes MRI can be normal. Still, person is having dementia. To diagnose, we do PET scan. PET scan is actually a concept is MRI structural. It gives idea about the structure of the brain. But sometimes structure may be normal at that moment and function may not be normal. So PET scan gives idea about that functional derangement. The concept of PET scan is like it will detect the areas which are not functioning or metabolizing normally. So it will detect those areas where the glucose uptake is less. Suppose a person having a Alzheimer's disease or frontotemporal dementia, his frontal lobe is not functioning normally, or his memory area is not functioning normally. There will be reduced uptake, and that will give a color coding. That's how we diagnose the dementia in early stage. These are the advanced modalities nowadays we have, and we diagnose the dementia in early stage using them, PET scan and all. This is classical mistakes sometimes they do. You can see the simple diagram. There is a pentagon and there is intersection. So they may make mistake. Sometimes they take a lot of time to draw. Here the person is making mistake like in upper is the pentagon, but you can see down he is ignoring some angles. Sometimes this is a very early form of dementia, and advanced form sometimes they do different mistakes. In Alzheimer's disease, you can see. I have asked them to, we call as clock drawing. This is also we do in our OPD practice. We give them certain situation, we ask them to draw this thing. So here he's making some mistake. Like I have given the time 10 past 10. So he forgot and he's keeping time at 11 past 10, and you can see the timing, the arms, they are not localized centrally, they are making it peripherally. In at moderate dementia they are making again mistakes, some angles number they are putting it outside the round circle. In severe dementia they can't do anything. So this how we actually OPD, we diagnose the person having different dementias and different cognitive domains by using some simple tricks. Now coming to management. So when I can say management, it is not only the medicines or treatment. That is a part of the management. Apart from that, that people need more management, more include their taking care. That is more important in any Alzheimer's patients or any dementia patient. So we have memory boosters. They work very well in early stages. We advance, we add doses. Sometimes we give combinations, and generally they do well in early to moderate stages. Then there are certain features which may need some different medicines. Suppose the person is very aggressive and it is disturbing him and other people, then we have to give some antipsychotics. Sometimes there is lack of apathy and such a low depressed mood and all, so we have to give the mood elevators. Insomnia, disturbed sleep is very common in dementias. So we have to give them sleeping pill at times. We try and avoid giving other medicine. It is as per the requirement. Maybe sometimes for short duration we have to give. Sometimes we have to reduce the doses because all these medicine they have sedation or sleep as a side effect. So we have to be careful in elderly giving medicine. Sometimes there can be associated other problems, so we have to treat them also. So these are medical management. Now coming to the diet, what diet should be taken? So generally we encourage fish, olive oil, avocados, fruits, fresh fruits, vegetables, nuts, beans, whole grain. Red wine in moderation is also recommended in dementia people. This is called a mind diet. What is mind diet? Mind diet like in stroke we have Mediterranean diet. It is actually diet which includes more of proteins and less of carbohydrates like thing. Similarly, there is a diet for the hypertension. So this is actually the diet which includes most of the principles of these two diets, Mediterranean dash diet. So this is a mind diet. So this is a hybrid diet which includes principle of both diets, and where we prefer more of a vegetable, especially green leafy vegetables, then fruits and berries. Berries are preferred over the fruits. Whole grains are better. Then we encourage more of a beans and nuts intake. Fish, at least one or three servings in a week. That is recommended. Olive oil generally is recommended, and we ask them not to take more of a red meat, sweet, cheese, some fast fried food. They are not good. Like in any person is having any vascular problem. Similarly, for dementia risk or those actually having dementia, we should avoid all
Dr.
this.
Shafale's connection has.
Hello, now it's better.
Can you?
Hello, can you hear me?
Yes, sir, you're audible, sir.
Audible, and my presentation is visible.
Yes, sir, perfectly.
Sorry for the technical snag. You missed a lot of slides, or okay. So ultimately, when I say management, it comes the person. So here the person is having dementia. He is not able to take care of himself. So it is a caregiver or family people who give the support. This is very important. Here, understanding is very important, because in dementia they forget simple things. They may not remember the birthdays. They may not participate socially. So it doesn't mean they don't like it. They don't know how to do it. So it is not deliberately they are doing this. Sometimes they may behave abnormally, or they may take poor judgment which not be in favor of the caregiver. So that causes some family conflict and also. But we should understand, we should keep yourself in the person having dementia, because he's forgetting things, so he can't take proper judgment. So we have to understand these people. We should take care, considering their cognitive domains affected. So a person is having some frontal lobe dysfunction. They can be unnecessarily aggressive, but it doesn't mean they are deliberately doing it. It is just because their frontal lobe is not functioning normally, so there is change in behavior. So we give medicines, but understanding is very important, because ultimately the caregiver, they are dependent for most of the activity of day-to-day life. So they need proper nutrition. They can't feed themselves properly. They don't know which is the healthy food for them, and also it is the caregivers or our family members responsibility to support them. So this diet and all, it is not for Alzheimer's people. It is for the caregiver. They should know these are the different things they should be included into their diet for the for better memory, or for healthy brain functioning. So this you can do. Then they need a mobility. Sometimes they prefer staying in a bed. So we have to encourage them for walk. We should do the physiotherapy. Suppose they are bedridden, so regular physiotherapy we should do. What happens? Suppose somebody is lying in the bed and not using their joints. There will be contractures of the joint. So there will be pain, secondary pain. So they should be mobilized out of the bed, especially in advanced stages. They should be out mobilized, because they will need support for all these same things. So we should make them mobilize 1 or 2 times in a day. We should make them in a chair. We should take them out of the home. We should do physiotherapy that will maintain our the muscle bulk and the joint functioning. In dementia, when there is a uh, parietal lobe affect, they can't remember the addresses, so they trying to forget. So nowadays there are different apps. Some watches are there. Smart watch we can take help. Sometimes nowadays I think when they have devised a footwear where the GPS is placed into the footwear, so that whenever they go out, at least family member will know. It is difficult, easy to find them. So these are the different modalities we can take the help of technology to come over this problem. So dementia is ultimately a problem. This whatever we are seeing now, maybe we may seeing more people when as a population, aging population will increase. So more and more people with dementia will come across. So we should support them. We should understand them, so whatever their behavior and all, rather than thinking, we should think in their way. If they are forgetting, that's why they are behaving like this. And we should then give social support. So that's how we can manage people with the dementia. I will stop here.
Yeah.
So most of the
Thank you
time,
very much. Thank
yeah,
you very much,
oh,
Doctor.
thank you.
You know, we are running a little out of time, but we have a few questions that have come in. Can I pose them to you, Doctor? We
Yeah,
have
sure,
four
sure.
questions
Yeah,
that have come
yeah.
in. All of them over here as: are there any tests for early detection of dementia? Is there any blood test or or some such thing? Is there a DNA test? Is it genetics test that one can do to figure that if one's parents or somebody in the family has had, one will get also.
So it is available, but not recommended for everybody. Suppose I am expecting some familiar form of Alzheimer's disease, then only I will advise a dementia test, a genetic test for dementia and Alzheimer's. Similarly, we have certain genetic syndromes which present as dementia. So it depends, not regularly. Like a person elderly having dementia, I will not advise the family member to go this test. Very few people who have a genetic form of dementia will diagnose. We can diagnose them by genetic test. There are certain markers nowadays, they are coming, maybe commercially available. We do CSF tests recommended, knowledge level and all. So we can diagnose that this person is going to get dementia. These are not routinely performed or not like we do health checkup. It's not like that test. We have to target the people and accordingly we can advise them.
Right. Thank you, Doctor. There is a question from Shamla Ravi. Her question is, what is catatonia? And what are the symptoms? What are the triggering factor? How to find out by tests? And what are the treatment options?
Catatonia is a form of actually behavior basically variant in these people. So they will resist. They will resist to the hello. Hello.
Yes. Yes.
They will resist the normal activity. So that is catatonia. So they will abnormal. They will keep your body in particular position like this. They will resist your movement. So when you do tests, like there is some weakness or no, it will not be weakness. It's a behavior problem giving right to particular rigid posture of body.
Right.
So we give some anti-psychomotor, some medicines, and generally we can control it by giving medicines.
Right. Uh,
Generally, rather than dementia, these are generally found in catatonia, more of a like a schizophreniform disorders, like we get catatonia rather than dementias.
right. Doctor, this is a question that has been asked in the past as well, but obviously, since it's being asked, there is a certain notion that it and a worry that exists. There is Sunita Verma who asks, is forgetfulness a sign of the onset of dementia?
Forgetfulness is a sign of onset of dementia, but here we should be categorical because all forgetfulness is not dementia. I'm explaining you. Suppose memory is not formed immediately. How memory is formed? First step is attention. Then there is a registration. Then there is a memory formation. Suppose I am preoccupied with something. I am not paying attention to something. And either will be forgetfulness or memory loss. So not all forgetfulness is memory loss. Sometimes, in fact, most of the time, it is inattention. Inattention causing poor registration and memory. So forgetfulness can be the symptom of dementia, but not always.
Like, there's a specific question that is coming from Mr. or Ms. Gupta, which is that if I come to the room and forget what I came for, is it dementia? Whether if I forget
Exactly.
whether I took a medicine or not, is that something to worry about?
Actually, I would say if it is one or two instances, if it is not happening regularly, then just ignore it. If it is happening regularly or it is same thing you are experiencing other domains, then it can be a problem. But I would suggest this is not a problem because it looks like more of a inattention. Memory, because this is like I'm not paying attention that I'm taking medicine. So it will, you can't register that moment. So you will feel that you are forgetting. So if it is isolated event, just ignore it.
Doctor, this is a question from Anjula. Her question is, and it's in Hindi, क्या डायबिटीज न्यूरोपैथी भी डिमेंशिया का कारण हो सकती है क्या?
डायबिटिक न्यूरोपैथी डिमेंशिया का कारण नहीं है बिकॉज इट इज अ न्यूरोपैथी बट डायबिटीज itself can be the one of the triggering factor for the dementias because like diabetes affecting your nerve, so diabetes also affecting some brain functioning also. The diabetic people have more of a vascular burden into the brain, So there will be more chance of developing forgetfulness as compared to normal people. In that way, it can be affected, associated, but not neuropathy will not cause dementia.
Doctor, this is a rather long question, which I want to tell you, and this is why we thought of having this session. It came to me 2 weeks back. Um can you please ask doctor as to what should one do about dementia? I feel very guilty that I did not take care of my mother's dementia. I did not realize that it was dementia. And now I'm in the US. Not able to take my mother uh, back. I'm not able to get my mother here because I don't know whether she will be able to take a 16-hour flight. However, I have tried my best to ensure that she is looked after. I have put cameras in the room, etc. But she is just not willing to go to a center for dementia patients. What should I do, and what would you advise caregivers like me?
Yeah, it's a difficult situation now. This situation is very common because the area where I practice, I see a lot of our kids are settled elsewhere, and elderly parents sometimes with different ailments, including dementia, are staying. One thing is a old age home. Sometimes they have to. Sometimes they get a close gated community, and also they get some support, nursing support, and some doctor support. So that is one of the way. But if he is not able to convince to the parents to go there, then they can have a maybe caregiver only, caretaker they have to arrange, and maybe a frequent visits by any nursing attendant to check their weight, blood pressure. And they can support in that way. They can have frequent video consultations, video rather than consultation, video calls, so that they can engage their have a rather than virtual engagement with the parents. So in that way, it can be helpful. Better way to take to the community where they have other people, they can actually discuss their
So
problems in
that's
that.
that's the other question that was there. That are there communities like these? Is there some kind of a course that one can do to ensure that one is doing the best possible thing under the specific conditions?
So here, see, if you want to take care, best thing will be staying with the person. That is the only way you can do best possible. Otherwise, you have to rely, you have to outsource the things, and you can engage virtually in most of the activities. Like you can have a schedule, like in morning we should be make sure that he's taking breakfast, taking, you can have that monitoring thing, and you have to arrange people to take care. So that is the only thing you can do from the remote area, remote place. You are staying somewhere else and your parents are there, but or you can have enroll them into the old age homes for some time. By the time you will come back, you can take them with you. So that is a practical solution. Or if possible, you can just fly back there, and that is the best way to actually staying with them. It is the best way to give support with them, support them. It is the best way to support them.
Doctor, what you're talking about is facilities in the big cities, or closer to the big cities, but in smaller town India, this problem, of course, would be major, right? In terms of caretaking facilities,
Yeah.
homes, etc., are limited in smaller towns.
Most of the people, they don't need old age home. They need home. Old age home is concept where their family don't, they are not able to handle them because of they are not staying there. So their concept comes of old age home. But ideally, these people should be kept in the home. They will feel more comfortable in their own home. So we should arrange all these things, because here, as I mentioned, medicine part is very minimum. Medicines or medications are for age, their age related problem. For dementia, they need empathy, they need a social support, they need a family care, nutrition, what you eat, they need that, but you need some assistant for their day-to-day activity. So rather than old age home, best place to take care of them is home, with taking assistance whenever required from the nursing staff or like that.
Doctor, I have a question that has come in. Can you request doctor to read out a message which I will record for my mother who has dementia, as to what can be said? And can you request doctor to speak either in Marathi or Hindi?
They want message for their parent from me.
Yeah.
Okay. आंटी अंकल, मैं डॉक्टर विशाल हूँ, मैं न्यूरोलॉजिस्ट हूँ. अगर आप भूल रहे हैं या फिर कुछ चीजें याद नहीं रख पा रहे, कुछ जजमेंट में आपको इश्यूज है, सो डोंट वरी. फर्स्ट ऑफ ऑल, आपके एज में अगर मैं जाऊंगा तो ये मुझे भी होने वाला है, सो डोंट वरी। ये जो प्रॉब्लम्स रहते हैं, एज रिलेटेड अनवांटेड इश्यूज रहते हैं, समटाइम्स यू डोंट वांट बट यू हैव टू एक्सेप्ट देम। सो वी आर देयर टू टेक केयर। आप आराम से, आप अपना जितना ख्याल कर सकते करिए। बाकी हम फैमिली मेंबर्स, एज अ डॉक्टर आई एम देयर, फैमिली मेंबर भी आपके साथ है, आपको सपोर्ट करेंगे। अगर आप कुछ इंपॉर्टेंट जजमेंट नहीं ले सकते, खुद की केयर नहीं कर सकते, डोंट वरी। ने अभी तक हमारे लिए जो किया है, आपके फैमिली के लिए किया है, नाउ इट्स आवर टाइम टू गिव इट बैक। सो डोंट वरी, वी आर ऑलवेज देयर एंड वी विल बी देयर।
Thank you very much, Doctor, for this thing. Unusual request, but I guess this is how it is.
Yeah.
Thank you very much once again, Doctor Dr. Vishal Chafale, for being here once again with seniors today. Those of you who have joined, I have put the link to Dr. Chafale's last session on the chat window, so you can go to that. And thank you to the team at Apollo Hospital for facilitating this. Before you go, Doctor, I would just request our producer to play a video of the new issue of Seniors Today magazine. It is out, going to be out tomorrow. It will be out perhaps this evening, and this is an issue that we've discussed on our health webinar. We've got a senior endodontist who's going to be who's written this. So this is on oral health and the aging adult. Yeah, can you just play this? So a good mix of articles, even if I say it myself. It's a little extra focus on health this time, because even our technology, article is on medical alert systems. But this is it, and it will be up on the website very soon. The magazine will be up. It's free of cost, so you can access it. Once again, I would like to thank Dr. Vishal Chafale for being here. It is the Ganpati weekend, and obviously one is taking him away, holding him from his family, his patients. So thank you once again. We will be back next Saturday at 5 p.m. Our session next Saturday, as of now, is going to be Dr. Asha Narde, who's going to be talking about dental issues. So do look at the magazine, read the magazine, and even if I sound like I'm plugging it, but do read the magazine and come next Saturday at 5 p.m. for the session. Thank you once again, Dr. Chafale.